So one of the one of the emerging areas is the use of MRD testing, and this is a rapidly moving field. Do you want to give us a
Sure. I mean, MRD has been shown by Berry et al. In a meta-analysis to be the most prognostic factor, both in pediatrics and adult ALL. So, but the question really is what technology to use. So we traditionally have been using flow cytometry, and there are more genetically based technologies. One is using the IgG rearrangement to track the T cell, the B cells, the malignant B cell in these patients, and there's evolving technology using either NGS, for example, or PCR droplet technology. But overall, the data set is actually very compelling that this is the strongest predictive matter for survival in patients with ALL.
I think the NGS technologies are fascinating. The most clinically utilized technology that's not flow-based, that's based on sequencing the heavy chain gene rearrangement, is the adaptive technology so far. There's another technology called CapSeq, which is looking at a panel of mutations that's selected as the most common mutations for that disease and then sequenced over time to look for the initial clone as well as emerging other clones, which may be relevant for ALL as well as for other lymphomas in the future.
Yeah, there was some data for CapSeq and diffuse large B-cell lymphoma with response to frontline chemotherapy that looked very, very promising. You know, I think I'm not aware of the same data for ALL, but you can imagine it would translate.
So now that we have those tests, how frequently or how often should we be doing them in the course of someone's disease?
Well, for ALL, I think the paradigm is you do frequently. So you have after induction phase, after consultation phase, you test for MRD testing and make the decision on that. The majority of clinical trials use pediatric-based protocols in adults and obviously also in young children. And kind of a time point of being still MRD positive at week 10, week 12, week 14 really is highly predictive of a patient actually having a truly chemo-insensitive clone. And then obviously also if a patient has re-emerging MRD levels during consultation and even maintenance phase, heralds always a relapse in those patients.
So tisagenlecleucel is approved in the multiply relapsed setting or refractory disease setting. How do you see that moving? Do we see that moving forward at this point, or how do we sequence? Where does it come into treatment of patients with this disease?
So I think right now it's approved in the setting of chemotherapy refractory disease, and so that's patients who fail, don't respond to their frontline chemotherapy or relapse after their frontline chemotherapy and then don't respond to a second line of therapy. And I think that more and more leukemia doctors are using it ahead of transplant, right? And there's an emerging question of whether patients who have a good response after CAR T-cell therapy then need to go on to have a consolidated transplant or not. There is a planned randomized study for tisagenlecleucel looking at CAR versus inotuzumab versus blinatumomab, and so when that study gets off the ground, you'll hopefully read out and let us know how we should sequence this with respect to the other CD19 targeted agents. But I think it's an unanswered question, but we all really have to think hard about giving a patient a CD19 directed strategy ahead of a CD19 CAR, because we are all worried about potential antigen loss and then that leading to decreased efficacy.
No, I think that's a really good point. But we also have to remember we cure most pediatric young adult patients with ALL with conventional chemotherapy. So it's those patients we don't that we really need treatments. We have now seen studies with blinatumomab and inotuzumab in the relapse refractory setting, which have relatively limited utility, I would guess, in that setting. But I think the blinatumomab is now approved as an adjuvant in MRD positive patients as well. So it's really interesting to figure out how to sequence CAR T cells if you're going to use a CD19 directed therapy just beforehand, in part because of the risk of potentially augmenting antigen negative escape, although I don't think we have much data on that at this point. So how do you fit right now blinatumomab into this strategy?
Well, I think the data of treating MRD positive ALL, blinatumomab is established in that field. So, which also inotuzumab is also an agent that has been explored to be combined with frontline chemotherapy. And there's some very compelling data, at least on the phase 2 trials, showing that that combination is something that you could use. So in my mind, both those agents, blinatumomab and inotuzumab, would be somehow integrated in frontline therapy. And then at the next step, when a patient relapses or remains still MRD positive, then the CAR T cells might be coming in to take care of business.
So Jason, how do we incorporate transplant? Is this going to be a road to eliminating transplant? Or are we, in the Ileana trial, I can't remember exact number, but it was more than half the patients had already failed an allogeneic stem cell transplant when they were then eligible to get this. And then we do know that, at least in the adult population, going on to a second allogeneic transplant after a failed myeloablative allogeneic stem cell transplant certainly has higher transplant-related mortality. So what do you think about this?
I think this is a big unmet need. We don't yet know the answer to this. And as you said, going for a second allotransplant is quite dangerous. We don't have a lot of data to suggest that's required. However, ALL patients who get a response and they're relapsed refractory already, responding to CAR T cell, it's quite tempting to consolidate them with an allogeneic stem cell transplant. So I think that this is an area that we don't have an answer, but the risk of relapse without consolidation is tempting for many people to consider an allogeneic transplant in that space.
Although I think in the Ileana trial, again, the majority of patients did not get second transplants. So we are truly looking at long-term outcomes in patients who did not get a second allotransplant. I can just comment on our adult population. We have looked at this, and our policy at the Fred Hutch is to transplant patients who have not had a prior transplant if they have a donor and they're transplant eligible. And we think that, with maybe the exception of patients with what we consider low-risk disease, which would be low LDH, normal or high platelet count, and MRD kind of going into the CAR T cell, that's the only group that maybe we think could just not get a transplant and have the same outcome. Although I know that's quite controversial.
It's controversial, we don't know, and as we get better MRD technology, perhaps we could look at not doing that in people who are truly deeply MRD negative, but that's controversial.